We've got a really exciting program here, and it's going to start with Gregg Stone. But before I want to do it, it's like we've made shockingly good progress with Stemi. Amazing progress over the last 30 years and really in 20 years. But we still have some challenges. And I think one of those challenges is really microvascular obstruction. And about 60% of our anterior infarcts have it, and they still don't. We need to be able to diagnose it acutely, and we need to be able to treat it acutely. So what we're going to do is start, and Gregg's going to start with the state of Stemi, past, present, and future, and talk about therapeutic solutions.
Great. Well, hi, everybody. You know, you've been doing this for a long time when they want you to talk about the past. Okay, so I'm going to try to give you an overview on STEMI, pathophysiology, treatments, and where we are. So I'm going to go way back, and because it's really important to go back to the early study of Reimer and Jennings, where they showed in animal models that there's a wave front of myonecrosis after coronary artery occlusion that goes from the subendocardium to the subepicardium, and after about 3 hours, okay, in the absence of modifying factors, you have a transmural infarct. So that's really what we're up against in many, many patients. So when you look at how you can get myonecrosis and cell death when you've got prolonged ischemia, the first is energy depletion, and that leads to mitochondrial death and cell death. Then there's this concept of reperfusion injury. Once you actually open up the infarct artery, the sudden rush of blood leads to all sorts of oxidative stress and other issues, and that also leads to secondary cell death. That may actually be 60% or more of the ultimate amount of myonecrosis. And then you have complement activation and other inflammatory factors which can trigger apoptosis, which leads to later cell death. So there's a lot of different processes to try to interrupt, but a lot of opportunities. And if you end up with a large infarct, of course, you get pathologic adverse LV remodeling, and that leads to heart failure, and that leads to increased mortality. So we've got to limit the extent of myocardial damage. And of course, I'm not going to go back too far because we know the best first way to do that is primary PCI. And from the original PAMI trial, on which I was honored to be one of the early co-investigators, to now 23 randomized trials of PCI versus thrombolytic therapy, we know that expeditious mechanical reperfusion saves lives, prevents reinfarction, prevents the hemorrhagic complications, including hemorrhagic stroke of fibrinolytic therapy, therefore reduces total stroke, salvages myocardium, gets patients home earlier, a little less recurrent ischemia, et cetera, et cetera. So that's been a huge success story. And a lot of the reason that primary PCI works compared to fibrinolytic therapy is because it salvages more myocardium. You've got much higher rates of TIMI-3 flow and better myocardial salvage, and that's been correlated with reduced MACE. So the first thing, once primary PCI was instituted, was a rush to get the artery open earlier. Okay, because studies like this from DeLuca and others came out to really demonstrate that time is myocardium. And the relative increase of 1-year mortality increased by about 7.5% for every 30-minute delay in getting the infarct artery open. So we entered an era where we would do whatever was possible to try to get the patients to the emergency room faster and then try to shorten door-to-balloon times. Unfortunately, we've been totally unsuccessful in shortening patient times to hospital arrival. Patients ignore their symptoms, they're very slow at activating EMS, et cetera. It's about 2 hours in the United States, and that really hasn't changed, but we have shortened door-to-balloon times. And as we've shortened door-to-balloon times from about 120 minutes down to about 80 minutes in the 1990s to about the mid-2000s, there was a corresponding decrease in mortality. And that was a really good thing. Although by multivariable analysis, only about 6% of this reduced mortality was associated with shortened door-to-balloon times. It was probably somewhat overemphasized. And perhaps that's part of the reason why, as we continue to shorten balloon times, as we ended up at the ends of 2010, from about 83 minutes down to about 67 minutes, there was no longer a corresponding reduction in mortality. We kind of got almost as much out of the system as we could. So I certainly recommend trying to shorten door-to-balloon time as much as possible, but it probably makes the biggest difference in the patients who present really early. So Bernie Gersh and I wrote this paper in JAMA that's been quoted a lot many years ago that shows when you think about the amount of myocardial salvage and mortality reduction There's this early period in the first 3 hours where you get about 80% of all of the benefit. And then after the first 3 hours, up to 12 hours and maybe even 24 hours, there's a benefit of getting the infarct artery open on arrhythmias and stabilizing infarct artery expansion, et cetera. But you've lost a lot of your early benefit. So given that the median U.S. symptom to ER time is about 2 hours, if it takes us an hour to get the vessel open, you can see we're right at that edge already with the symptoms to balloon time about 3 hours, where we've lost a lot of our opportunity for mortality reduction. So we've got to focus on other areas such as reperfusion injury and trying to prevent apoptosis. So for this reason, when you really look at what's happened over the last 20 years, we've not made much progress. Mortality has been pretty constant. These are non-shock anterior myocardial infarctions from a large database. The anterior patients with anterior infarcts have about 10% one-year mortality, about 15% two-year mortality, about 20% heart failure and readmission rates. And that's been very constant over the last 15 to 20 years. So we're not making progress. We've stalled. And I'm not going to talk about cardiogenic shock in this talk just because of limits of time, but you all know that story. So the greatest limitation, I believe, of primary PCI and STEMI is poor recovery of LV function. And I really like to show this case because it reminds me of the issue. This was a 49-year-old man we took care of who had crushing chest pain, presented at the hospital at 90 minutes. And here you can see his acute infarct artery, total thrombotic occlusion of the proximal LAD. So here's his acute left ventriculogram. This was in the Horizon study where we were doing acute LV grams, and then we brought the patients back at 13 months. And you can see he's got akinesis of the anterior wall, apex, and dyskinesis of the distal apex and inferior wall. So we do a PCI with a door-to-balloon time of 67 minutes in this case, and we get a great result with a stent in the proximal LAD, TIMI 3 flow. And we bring him back 13 months later, arteries wide open, the stented area is the best part in the artery, TIMI 3 flow. So we must have improved this patient, right? Well, here's his LV gram just to remind you at baseline, and here's his LV gram 13 months later. Okay, we've salvaged almost no myocardium. In fact, you can see now there's a little bit of thrombus in the apex of the heart, and this patient's NYHA class 2 with heart failure. So that's so disappointing. We've got to do a better job. Why is this happening? Is it all time to infarct opening? And that patient wasn't all that bad. Well, the first thing is that infarct size is a huge prognostic predictor. Okay, and this is one of the reasons why things are still flat. We did a patient-level pooled analysis from 10 randomized trials and 2,600 patients that looked at infarct size between 3 and 5 days with either cardiac MRI or technetium-99 sestamibi. And looking at infarct size in quartiles, these are non-shock patients, the median infarct size is 18% of the left ventricular mass. That's really large. And as you go from the lower quartile, which is less than 8%, to the upper quartile, which is greater than 30%, you can see you've got an 8-fold increase in both death, heart failure, hospitalization, and the composite. And in fact, when we looked at that trial from Horizons AMI, where we brought the patients back, in 44% of the patients, the left ventricular ejection fraction goes down. Actually, LV function is getting worse within the 1-year period. The overall improvement in LVEF is only about 2%. So 44% are getting worse over time compared to their acute infarct left ventriculogram. So part of the problem is that we think we're so great at primary PCI, but we're not. Okay? Yes, we can get epicardial TIMI 3 flow in 85 to 90% of patients. And that is correlated with improved outcomes. However, the real goal is to get blood with oxygen and nutrients into the myocardium, and even better than that, to stop the acute injury process, restoring normal myocardial metabolism. So if you look at myocardial blush, the angiographic surrogate of getting blood into the myocardium, it's only 50% times are we successful, and that correlates really well with the likelihood of getting complete ST segment resolution within 90 minutes, meaning the injury is stopped, only 50%. So we are only successful half the time in the cath lab. So you have to know, as clinicians would say, a man or a woman has to know their own limitations. And a lot of the reason is what's going on in the microcirculation. As you know, 90% of the blood flow is the microcirculation. It's the blood vessels that we can't see on an angiogram. And you can get this no reflow phenomenon, where you've got, despite an open epicardial coronary artery, you can get absolutely no blood flow going into the microvasculature. There's a whole bunch of causes of this, from vasospasm to distal atherothromboemboli to endothelial swelling to white cell and red cell plugs, rouleau formation, and extensive myonecrosis with just obliteration of the capillary bed system. There's a lot of reasons that we get the so-called no reflow phenomenon, but it's probably the number one cause of why we don't salvage myocardium. So you can measure microvascular obstruction. You can possibly do it in the cath lab, and there's, with pressure flow wires, looking at the index of microcircular resistance and other measures, still research tools, but you can certainly measure it using cardiac MRI 3 to 5 days after the procedure. And we look for microvascular obstruction as an area of delayed hyperenhancement, and that's present in about 57% of patients. And this is 7 primary PCI trials in 1,700 patients. And you can see when you've got the upper third of patients with delayed, with microvascular obstruction, you've got an increase in all-cause mortality. And if you compare microvascular obstruction to infarct size, there is a correlation, but it's a relatively weak correlation. Sometimes you get microvascular obstruction with smaller infarcts. Other times you get no microvascular obstruction with larger infarcts. While they are correlated, it's somewhat weak. So when you put all of this into a multivariable model, both infarct size and microvascular obstruction are both independent predictors of all-cause mortality. Infarct size was a better predictor of heart failure hospitalization in the next year, but both predict mortality. So how can we improve myocardial recovery? So people have really focused on 4 areas. Early on was epicardial reperfusion and systems of care. I'd say we've done a pretty good job with that. You can always do better, but I think we've probably close to maxed out on what we can do. We can try to improve microvascular integrity and function with a variety of drugs and devices. We can try to trigger a bunch of cardioprotective reflexes and reduce reperfusion injury with a variety of drugs and devices. And then if last comes to last, there's always cell therapy. So unfortunately, this is easier said than done. This is a partial list of 30 or more pharmacologic agents which have been designed to reduce reperfusion injury, improve mitochondrial function, and prevent cell death and or apoptosis, which have failed. And here you can see the names of all of these, you can see the trials, you can see their proposed mechanisms. Every single one failed. We haven't done much better with devices. These are cardioprotection devices that have failed: aspiration thrombectomy, distal protection, and more recently, pressure-controlled intermittent coronary sinus occlusion. Failed to reduce microvascular obstruction in randomized trials, failed to reduce infarct size. Here are some promising but unproven device-based cardioprotection approaches in Stemi, and there's some evidence for these, but to date we lack definitive randomized trial data. Intralesional glycoprotein 2b3 inhibition and stent-based mesh thrombus exclusion were shown in small randomized trials to reduce infarct size, but no clinical outcome studies. Mild systemic hypothermia, mixed data. And then there's LV unloading by Impella, which is very interesting, and I don't have a lot of time to talk about this, but this talks about unloading the left ventricle for 30 minutes before performing primary PCI to not only decrease oxygen supply, decrease oxygen demand, improve supply, and trigger cardioreflective pre- and post-conditioning processes. So there is the STEMI DTU pivotal trial, which is ongoing, and actually this is completed enrollment. I was one of the co-PIs of this trial. Bill O'Neill and Naveen Kapoor are the PIs. We enrolled 688 patients with anterior STEMIs within 1 to 5 hours of symptom onset, and we randomized them successfully to a Impella CP with a 30-minute waiting period before you were allowed to do PCI. That's like torture, okay? But in the pilot trial, it was proven to be safe. 30-minute waiting before PCI versus go ahead and do expeditious PCI with no unloading either pre or post PCI unless shock would develop. And the primary endpoint of this trial is CMR infarct size at 3 to 5 days. So we enrolled 688 patients, and follow-up is ongoing in this study. And then you're going to hear a lot about, at this meeting, on the current generation of optimized supersaturated oxygen delivery, in which we take the patient's own blood, we hyperoxygenate it in this console, and we re-inject it into the infarct artery after the PCI is done. The blood containing 760 to 1,000 millimeters of mercury of pressurized oxygen, and that is like putting the patient into a hyperbaric oxygen chamber. This is the only trial to date that's been completed with a pivotal randomized trial, the AMIHA-2 trial, which we led in 382 patients, that showed a significant reduction in infarct size from 25% of the left ventricle in anterior infarcts to 18.5% of the left ventricle, a 6.5% difference, which would, while not powered for clinical outcomes, should correlate with about a 25% reduction in one-year mortality and heart failure hospitalization. So this was a really rapid overview. If I was to summarize primary PCI and STEMI, the state of the heart, primary PCI restores epicardial TIMI3 flow in 85 to 90% of patients and reduces infarct size compared to fibrinolytic therapy, improving survival in STEMI. That's the good news. But nonetheless, despite successful primary PCI, as evidenced by epicardial flow, microvascular flow and myocardial salvage are frequently suboptimal, resulting in large infarctions with adverse LV remodeling, heart failure, and death. Supersaturated oxygen delivered post-PCI is the only FDA-approved device-based therapy shown to safely reduce infarct size in a pivotal trial. And the ongoing STEMI DTU pivotal trial will determine whether LV unloading with Impella CP prior to PCI also reduces infarct size in anterior STEMI with mechanisms that would be complementary to supersaturated oxygen. Thanks very much.
Thank you so much for that fantastic overview, Greg. I'm going to take this time to introduce our panel. I'm joined by a really fantastic set of people here today. My co-moderators are Dr. Hari Naidu, rising president of SCAI, ex-president of SCAI, Dr. Henry, and then we've got a fantastic panel of speakers and presenters, including Dr. Rajiv Jauhar, Dr. Sandeep Nathan, Dr. Michael Lim, and Dr. Fuad Jan. Thank you for joining us today. With that, I'd like to call up Dr. Nathan for the next presentation. Microcirculation is the myocardium. You only get one chance. We also have Dr. Dave Cohen, and we're going to be asking you a lot of questions about the cost effectiveness of SSO2.
Well, thank you. Thanks so much, Mega, for introducing me and for a fantastic overview of STEMI care by Dr. Stone. So I'll sort of pick up where Greg left off here and talk a little bit about the microcirculation. Here are my disclosures. So Dr. Stone already talked a little bit about microvascular obstruction. The clinical features of microvascular obstruction are summarized on this image. The two boxes, I think, are really the sort of take-home messages. The prevalence is between 10 and 67% of patients with ST segment elevation myocardial infarction. And so, you know, if we were confronted with a 10 to 67% chance of rain today, we'd be unhappy with that, right? That's a pretty widespread, and so I think the point is that a lot of patients have it. We just don't know how many, and it varies with the type of MI and so forth. And the prognostic implications in the second box summarize why we should care about this. Every 5% increase in infarct size leads to a 19% increase in all-cause mortality at 1 year. And similarly, every 1% increase in coronary microvascular obstruction leads to a 14% increase in all-cause mortality at 1 year. And there's obviously overlap between those two. Some of the mechanisms of coronary microvascular obstruction, to add a little bit more detail to this, is shown on this slide: ischemia reperfusion with all of its attendant molecular mechanisms and cellular mechanisms, distal embolization, which we try to treat with increasing intensity of antiplatelets and anticoagulants with limited success. And then we're becoming aware of individual susceptibility factors that are patient-specific, and we really can't do a whole lot about that when somebody presents to our cath lab at 2 in the morning. The consequences on a cellular level are shown on the right side of this slide. The vascular endothelium is relatively resistant to ischemia. It swells, but in the setting of reperfusion, many of these capillaries burst as well. And intramyocardial hemorrhage, which is easily discernible on cardiac MR, is the footprints of irreversible, those are the footprints of irreversible cell death and injury. And unfortunately, a lot of patients with anterior STEMIs enrolled in trials who undergo CMR, this is not uncommon at all to see cell death and intramyocardial hemorrhage. So, you might look at this and say, well, if somebody has no reflow, that's a problem. Even if we fix it, there's going to be some degree of damage and persistent ST elevation and so forth. These are all indicators that bad things are happening. And that's certainly true. If you look at the right column where there's no reflow observed, 30 out of 31 patients also have microvascular obstruction. The problem is that if you don't have no reflow, more than 50% of those patients also have microvascular obstruction. So no reflow in the cath lab is a very coarse metric. When you see it, it's bad. When you don't see it, it's 50% of the time it's still bad. And so that's, I think, the challenge that we're faced with as clinicians. And, to make this real, I'll show you a patient who ironically had the same door-to-balloon time as the case that Gregg presented. This is a young man, 37 years old. When I first met him in the context of an anterior STEMI, he had 1 hour of ischemic time. He's very well educated and knows that something is terribly wrong, so he calls EMS. He gets into our cath lab right away. A lot of thrombus in the LAD, but we got everything open. Prompt resolution of ST elevations. He's quietly sleeping on the cath table, all branches preserved, good blush. And then 2 months pre-STEMI, you could see what his ECG, what his echo looked like. His primary care physician had obtained an echo because he had a history of hypertension. 1 day post-STEMI, his apex is not happy. EF is 35%. 1 month post-STEMI, his apex is still unhappy, and now with a clot. And 1 year on all the GDMT he can tolerate at his blood pressure, his EF is now 45%. So this is the unfortunate reality. Despite a door-to-balloon of 67 minutes, TIMI 3 flow, immediate chest pain, and ST resolutions. Dr. Stone has already touched upon this. There are a few therapies in the pipeline, and one therapy that's FDA approved for reducing infarct size. Hyperoxemic reperfusion with supersaturated O2 is the only FDA-approved therapy, and of course, we'll know soon about the value of LV unloading in anterior STEMI without cardiogenic shock. And there's a compound, a sodium iodide analog that's being investigated by Faraday Pharmaceuticals. Iosite AMI3 is a study that's enrolling, and we should have some data from that in the foreseeable future as well. SSO2 is a closed-loop system with about a 5-minute setup that administers hyperoxygenated blood into the left main and down the LAD in anterior STEMIs. It can be performed using a coaxial 7 French femoral or radial system, femoral system or radial femoral delivery. If you started the case off as a radial case, you can put in a 5 French draw line in a femoral artery and draw off of that, hyperoxygenate and reinfuse it. It's a 60-minute setup, which is a step down from the original 90-minute setup with 90-minute infusion time with 75 milliliters per minute. 60 minutes for 100 milliliters per minute is what's FDA approved. And the wording of the label is up to 60 minutes, so whatever the patient can tolerate. The potential mechanisms of action are summarized here. Hyperoxemic reperfusion is believed to work through the diffusive effect of superoxygenated plasma. So the concept is that if you have microvascular obstruction and RBC traffic is impaired, hyperoxygenated plasma can deliver O2 independent of that. There's reduction in endothelial cell edema with restoration of normal microvascular flow sooner. And then there's potentially mitigation of free radical injury. This has been validated in animal models by downregulation of myeloperoxidase levels. In radio-labeled microsphere experiments performed in animals, you can see that there's about a doubling of blood flow to the ischemic territory in SSO2-treated animals. And this is what it looks like on a gross specimen. The control animal, after 60 minutes of balloon occlusion of the LAD, has a very large and dense scar that's transmural. The SSO2-treated animal has some patchy infarction. The clinical trial program is summarized here. 670 patients in all. AMI-HOT-1 was inclusive of anterior and large inferior STEMI with up to a 24-hour ischemic time. AMI-HOT-2 really sort of narrowed that down to anterior STEMI with 6 hours of ischemic time or continuous ischemia. In AMI-HOT-2, this was SSO2 administered through an infusion catheter, which was modified in IC-HOT, which was a confirmatory PMA study. So the duration of the infusion shortened to 60 minutes and infused through a 5 French diagnostic JL4 catheter in the left main. And if you look at the pooled analysis of AMIHOT 1 and 2, inclusive of anterior STEMIs and 6 hours of ischemic time, there's about a 26% relative risk reduction in infarct size, which correlates to a reduction in heart failure hospitalizations at 1 year. And what's particularly interesting is that it's not just the people that you thought would benefit from this, meaning if you had a long ischemic time, if you had impaired flow, well, those patients need all the help they can get. It's actually the patients who have short ischemic times and good flow at the end of the case that also benefit, and perhaps to a differential degree. This is what the actual setup looks like. This is obviously femoral coaxial setup with a 7 French sheath that has a high flow sidearm that you draw off of, and a 5 French diagnostic catheter that's returning the blood into the left main. If you start the case as a radial case, your return can be through radial. Your draw line has to be from femoral, although there's some experience, and we can certainly talk about it on the panel, some experience with biradial approach and using a radial to peripheral sheath to draw out of the descending aorta. The vascular access configurations are shown here. With coaxial femoral access on the left and radial femoral access on the right, with radial as the delivery and the femoral access as the draw site. It's imperative that you maintain anticoagulation for the duration of the infusion, which is up to 60 minutes. And this stopcock with the green port here allows for continuous measurement of ACTs. You can actually transduce a pressure off of it. Also, one of the concerns is that you have an anterior STEMI patient on the table for 60 minutes without being able to measure a pressure without interrupting the circuit. You can actually transduce a pressure. You do get artifact due to the roller pump from the draw line, but you can measure a pressure off of it as well. So what are the challenges to adoption of SSO2? This was approved in 2019. We had this little pandemic thing for a couple of years that sort of dulled everyone's enthusiasm for new technologies. And now there's about 1,200 or so commercial cases that have been performed, mostly in the United States. So a lot more than 1,200 anterior STEMI. So what are the challenges to adoption of SSO2? One is availability of off-hours case support, although this is actually quite simple to set up and administer. The second pain point is an additional 60 minutes of case time, but unfortunately, you don't get a second bite at that apple where you take the patient to the CCU and then bring them back the next day when it's more convenient. There's concerns of hyperoxemic reperfusion and free radical injury, which have not been borne out in animal or human data. There's patient safety and stability post-PCI. And then the other pain point, of course, is femoral access. As we shift to a radial-first approach, we worry about femoral access. I'll just sort of touch upon the last one. I think that, as a radial-first operator, I firmly believe in radial approach as an easy and reproducible way of reducing vascular injury and bleeding. However, we have anchored around some historical data in terms of femoral access bleeding complications, and this is more recent data from the Veterans Administration. Jake Dole published this a few years ago, looking at the convergence of bleeding with diagnostic coronary angiograms. There's still a separation of curves for PCI cases performed from a femoral in orange versus a radial in teal approach. However, the difference is quite small. The difference is about 1% in this analysis, and with best practices, use of micropuncture, ultrasound, and so forth, iterative fluoroscopy, I think that risk can be mitigated. The last thing I'll say is that what's recommended in the IFU and the packaged equipment is a 7 French femoral sheath with a high flow draw. In the last 5 cases or so that we've done at our institution, we've done about 22 cases. We've actually put a 7-6 radial sheath in the femoral artery and drawn off of that, and that's worked out just fine. We pulled the log files. There's no issues from the log files from the machine suggesting that we're having suction events and so forth, and we've been able to complete the 60-minute infusion. And so there is a difference. If you say, if you're going femoral, what's the difference between 6, 7, and 8 French? There's actually a difference in bleeding if you have a large enough data set. And so if this can be reduced even further in terms of vascular access, that's a good thing. Last thing I'll say here is that we are actively collecting data in the SCORE registry. I have the privilege of serving as the national co-PI of SCORE along with Bill O'Neill. And this is a prospective study designed to collect real-world data to examine the clinical impact and the economic impact of SSO2 therapy. In total, we'll have 1,000+ cases, 500 cases that are prospective control cases, anterior STEMIs that would have met labeled indications for SSO2 in whom SSO2 was not administered. Those are the controls, the SSO2 on-label cohort, which is another 500 treated with SSO2, and then SSO2 all-comers, including off-label cases. So however many cases we collect there. The study is off to a good start, and we're enrolling at a brisk pace at up to 40 sites around the U.S. and outside of the U.S. I'll stop there, and thanks so much for your attention.
Before we go on to the next one, we'll maybe do a couple of questions so we make sure we get through some of this a little bit. Let's go down the panel a little bit in terms of, let's start with Rajiv, Dr. Johar. There's two hurdles to adoption of these types of technologies. One is the institutional in terms of the cost and the logistics, but the other is the physicians themselves. So how'd you get over the hurdle in terms of, we're used to getting them out of the lab, making sure there's no arrhythmia, getting them safely to the CCU, and getting them out of the hospital. How do you make the leap and convince people that it's more important to look more thoroughly and to look at these larger, longer-term endpoints such as heart failure readmissions and infarct size? Buy-in, that's what I'm talking about.
Is it working? Everything? Okay, no one here? Oh, okay. Look, Harry, that's a great question. I mean, I'll give you an example. In 2015, I moved hospitals, and I moved to our sister hospital where they didn't do any impellers. And the initial inertia to put impellers in was extreme. But as a physician, when I explained to the staff its benefits in certain situations, it worked. The same thing happened with SSO2. I mean, I can tell you the elephant in the room was the 1 hour window and the fact that most of our cases were radial. But when I showed my staff the benefits, especially our own internal cases. Because you know what, data is great, but if you show your staff and your doctors your internal data, you bring a case, Mr. James came in and he had an MI, you remember him? Now look at him, look at his echo now. They're believers. And now we've done, I think, 27, 28 cases. And when we have an anterior wall MI, our staff pulls the machine and brings it right in the room in anticipation of its use. I think we're always high-fiving each other. Oh, we got great results. It's macrovasculature, but the reality is we still have a long way to go, and that's the problem.
Yeah, I think that we all see these patients and we think we do it so quickly. You can do dordaglutine's 20 minutes, 25, they come right in, and then we assume the next day that they're going to look great and the infarct area is small, but we don't always know. I think that's what I took away from some of the lectures so far. Anybody else comment on that?
Just so much we don't know. I mean, there's the other side of the coin, which is the patient who comes very late, way past help, and still gets a primary, a PCI, or even doesn't. And the ventricle looks bad, and in 6 months on fantastic medical treatment, the ventricle looks amazing. So it's not just all about the blood, and there's just a lot that we don't know. I think we're putting too much emphasis on this when there are so many more factors involved.
Just a quick comment about that, the very late. Jay Travers just published from Minneapolis Heart, published a series of patients that presented after 12 hours and that all got SSO with outstanding results, really encouraging results. So I think the late patients might be even an optimal population because there is higher MVO in that late patient. And I think the big issue is trying to figure out MVO, and a huge unmet need is our ability to diagnose MVO acutely. And we're going to be able to do that, I think, very quickly.
Yeah, I would agree because it's what we don't know. You're right, which is that if they come late, we're not supposed to do it with the PCI, right? It's a closed artery. We may do more harm than good, but why is that? So it could be that this is a different frontier that allows us to acknowledge and treat those patients that heretofore we're not having any option. We don't have that data yet, but I think it could be that some incremental data moves in that direction.
All right, with that, I'll introduce Dr. Dave Cohen. As we look at these therapies, the question always becomes, is this cost effective? And so he's going to address that for us today in terms of talking about highly cost-effective therapies in STEMI.
Well, thank you, Megha. Thanks, Hari. Thanks for everyone for being here and for Zoll for putting this on. About a year ago, the folks from Zoll came to me and said, this economic issue is real and we need to deal with it head on. We'd like for you to conduct a cost-effectiveness study of infarct size reduction. And I thought that would be very, very, very interesting. There's a lot of good science, as you've heard here, but nobody's really tried to sort of see what the actual downstream consequences are. And that's what I'm going to be explaining to you here today. These are my disclosures, including research grants and now a consulting agreement with Zoll. So as you've heard, SSO2 therapy is the only approved therapy that's been shown to reduce infarct size in patients with anterior STEMI. But in the absence of a proven mortality benefit, concerns have been raised about the cost effectiveness of this strategy. I think if there was a mortality benefit, you wouldn't need me to be standing here, or you wouldn't need this whole symposium, because it would be blatantly obvious this is what we should be doing. And so to address this evidence gap, what we did is to develop a decision analytic model, a mathematical model, to evaluate the long-term clinical and economic outcomes of SSO2 versus standard care, and to assess its cost effectiveness over a patient's lifetime. This isn't just about what happens in the next week or the next month, but it really is about a lifetime of benefit. This is the structure of these models. It's actually pretty simple. This is one of the simpler ones I've done. We modeled this off of AMI-HOT2, so we were talking about 61-year-old patients, 77% of them as male, with an expected infarct size of about 25% of the left ventricular mass. We essentially mathematically, or in a computer, randomized them to SSO2 therapy or no SSO2, and then we modeled two long-term states, whether the patient had heart failure or whether they didn't have heart failure. And then every single cycle through this model, which was a monthly cycle, we allowed the patients to either survive or to either die from a cardiovascular cause or non-cardiovascular cause, and among the patients who survived, they could develop heart failure. And then, again, after that, they would just repeat the cycle. The medical outcomes, the outcomes that we tracked with this model structure are survival, life expectancy, quality-adjusted life expectancy, typical things that we look at in economic analyses, as well as the lifetime costs, and then cost effectiveness, which was assessed in terms of dollars per quality-adjusted year of life gained. Now, the structure is very easy. The business end of this work is what goes into the model, because I think we all know garbage in, garbage out. And I think when you look at what the assumptions were, they're very, very reasonable, and they're actually very strong. You already heard Gregg talk about the data that he pooled a number of years ago, looking at the relationship between infarct size and one-year mortality and heart failure. And that really is the engine that drives all of this. The only assumption in this model really is that Gregg is a good scientist, and Gregg can vouch for that. And that the data that he published are causal. That if we reduce infarct size, these things will happen. His study was, was an observational correlation study. It makes sense that it should be causal, but it hasn't been proven, I would say. So that's an assumption. The annual cost after anterior STEMI with or without heart failure came from Medicare data, looking at patients who were and were not hospitalized. Cardiovascular mortality after anterior STEMI, we lucked out, and there was this beautiful Danish population registry that was just published last year, looking at 10-year outcomes after all different types of anterior myocardial infarction in the entire population. Perfect data there. And then the incidence of heart failure and the prognostic impact after anterior STEMI, again, came from Medicare data. The two assumptions related to SSO2 was the estimated effective SSO2 on infarct size came from the AMI-HOT2 trial. and the cost of SSO2 therapy, which came from the folks at Zoll, who estimated this at about $10,500, which includes not only the equipment and the delivery cartridge, but also includes the time in the cath lab, as well as the professional fees for this additional time. So that's the cost. And I want to just point out one thing, which is sort of my mantra whenever I do these theoretical models, is that whenever we came up against something where there was an uncertainty, we made the worst possible assumption for SSO2. And I like to do that because if that way you know if the results come out pretty positive, well, it's not because they've made biased assumptions. And so that is what we did. So this is the first thing that we found in this study as we ran that model over a patient's lifetime. And what we found was there were a lot of cost savings. So this is the cost offset over time. And you can see it rises rather rapidly in the first 10 years, but it continues to rise out to about 30 years or so. And it ended up being a little over $9,000 over the patient's lifetime, and that's from avoidance of heart failure and all the costs that are associated with patients having heart failure, including hospitalizations as well as medications to treat their heart failure. These are the primary results of the analysis. So the initial cost, $10,500 for SSO2, no additional cost for standard care. The follow-up costs, I didn't show you the actual numbers. The guy only showed you the difference, but they were about $150,000 versus about $160,000, so a difference of about $9,000 per patient. That means the net lifetime cost, what did you pay after you got back all those savings, was just about a $1,300 cost. The gain in quality adjusted life years from avoiding heart failure, from avoiding the excess mortality associated with heart failure, and from avoiding the decrement in quality of life associated with heart failure was about 0.1 years, quality adjusted life years, and that's actually pretty reasonable for a therapy like this where it hasn't been explicitly shown to improve mortality. And so if we just take the ratio of these two quantities, we get a cost effectiveness ratio of about $12,500 per quality adjusted year of life gained. Now, to put that in another way, this is these diagrams that I've been showing for a long time, looking at the joint distribution. So here we've taken all the data and we have allowed all the parameters where there's uncertainty to vary across their range. And we iterate this multiple times. In this case, we did it 2,000 times. There's 2,000 dots on this screen, and you can see where they're distributed. This star is the base case. That's the center of all of that distribution with that cost of about $1,300 more and a gain in quality adjusted life years of 0.11 years. But what we can also do is we can impose a threshold. So this is a $50,000 per quality adjusted year of life gain threshold, which is considered to be high value in the United States. And all the dots that are below and to the right of this line are the reiterations of the trial where we met that threshold. And you can see that about 70% of the time we met that threshold. Now, we can look across other thresholds. So this is what we call a cost effectiveness acceptability curve. This shows the probability that the therapy is cost effective at a range of different thresholds. And again, I already showed you this $50,000 per quality adjusted year of life gain threshold. But what about $150,000, which is considered to be reasonable value in the United States at least? Now we're up much higher. We're up to about almost 90% probability that this is a cost-effective therapy at that threshold, which is very reasonable. Again, in the United States, we consider $50,000 or less to be high value, $50,000 to $150,000 to be intermediate value, and SSO2 is way down the bottom here, a very, very high value therapy, certainly in the United States. And if we look across a whole range of other heart failure therapies, things like CRT and ICDs, here's another one of Gregg's trials, the COAP trial, MTIR. Here's the original TAVR trial, the partner B trial, where we ran the cost effectiveness analyses. You can basically see that SSO2 beats the pants off of almost all of these things, including drugs like SGLT2 inhibitors. So again, I think there's a lot, this really is a very, very favorable estimate. Finally, I just want to point out a couple of other things. So, this is a model. There are different parameters. We had certain starting parameters. And so one of the things we can do to kind of pressure test this model is to say, what are the thresholds? Where does it fail to meet the cost effectiveness threshold? And you can see age is an important factor because obviously the older the patient is, the less years of life that they have ahead of them, the less cost that will be saved from avoiding heart failure. And you can see that the cost effectiveness of SSO2 remains high value, less than $50,000 per quality adjusted year of life gain for men who are under the age of 72, for women who are under the age of 74 because they live longer. If the infarct size is great, as long as it's greater than about 20%, it looks very highly cost effective, and the cost of the therapy could actually theoretically go up about 50%. And if we accept intermediate value, now we could say that it's probably cost-effective for men and women in their 80s, at least in their young 80s. If the infarct size is down around 14%, which is, it's now we're capturing almost all anterior STEMIs, and if the cost of therapy were to go up some ridiculous amount, and I don't want to give Zoll any good ideas about that. Finally, very importantly, the threshold, the perspective that I've been talking about is a lifetime perspective from a societal perspective. Is this a good thing to do? Is this good value for money for our patients across the healthcare system? Obviously, your hospital administrator doesn't really give much about that. Hospital administrators care if they're getting reimbursed. And as far as I'm aware, there is no special reimbursement for SSO2 therapy in the United States. But what Zoll did is they did a study looking at where these patients ended up getting billed, patients who were getting SSO2 therapy. And what you can see here, they're spread across a variety of different DRGs, but about 30% of them end up in this very high-paying DRG of DRG 270, which is with major comorbidities and complications, where your hospital is clearly going to make money on it. Now, I'm not here to endorse how you do this, but I'm just telling you that out in the real world, where you practice, you put in all the information into the medical record, and the coders are putting them into these different categories. So it does seem like there is ways that sites are recouping a lot of the cost here. So to summarize, as we've heard from the previous two speakers, in patients with STEMI, reducing infarct size by avoiding reperfusion injury is critical to achieving further improvements in long-term outcomes. And despite promising preclinical data for many drugs, every one of those things that Gregg showed on his slide that didn't work in humans was tested first in animals and worked in animals. So animals are not very predictive in this space. The only therapy that's proven to reduce infarct size is SSO2 therapy. Based on this disease simulation model that I kind of gave you the very quick and dirty look at, and using, very importantly, very conservative assumptions, we project that adjunctive SSO2 is highly cost-effective from the perspective of the U.S. healthcare system for the patients who are on label, patients with anterior STEMI presenting within 6 hours of symptom onset for primary PCI. The economic value is clearly higher in younger patients with larger anterior infarcts. Everything is lined up for them to get maximal value. And I would say from my perspective, as somebody who still does primary PCI, on weekends at least, these findings are reassuring and should motivate the continued investigation of other novel approaches to limiting infarct size in patients with STEMI. Thanks very much.
David, that was outstanding work.
Yeah, we've looked at it, and I'm still waiting for an answer on the RVU question, but the 22 cases we've done have been cost neutral to, slightly profitable.
Yeah.
I'm not 100% sure about the reimbursement on that. I don't think I've looked into that, but I guess we have Teresa here. I don't know if she knows the answer to that question.
For us, it's all about documentation. If you document well, you'll get reimbursed.
No.
We did have in the EMR, we had made a dot phrase when we do the SSO2, so I think that's what we were told to do, and I'm sure it is reimbursed. I'm not sure.
All right, in the interest of time, really appreciate that from you all. In the interest of time, we'll move to our last speaker. Mike Lim's going to talk about the investigative approach versus standard of care, LV unloading.
All right, thank you. So, whirlwind tour following Gregg, which I'm going to repeat a couple things that he said just to remind us, and then Sandeep's excellent discussion on SSO2, and thank God Dave's around to tell us whether things are cost effective or not, because I don't know anybody else that can do it. But, I want to remind us that this is what we do every day. And this list of things that we do every day and how to take care of STEMI are years and years and years in the making. And if we look at the defect-free performance, which we're all judged on by NCDR, this is 14 metrics for every single patient that has to happen every single time. And this is our performance across 222 hospitals in NCDR through the years, and we do pretty well. These are things like aspirin, beta blockers, high-intensity statins et al. And yet we've always focused on door-to-balloon time, and all these other things are things that we've left to the nurses and the advanced practice practitioners and others, right? But I want to really bring us back to the patients. And so Gregg showed you a case of an anterior MI. Sandeep showed you a case. I'll show you 4 cases that I did late last summer. All 4 of these cases had door-to-balloon times less than 90 minutes. Our cath lab in Poplar Bluff is right next to the emergency room. I mean, it's almost in it, so there is no time. And they all got open. And they all got reperfused, and they all had defect-free care. But 3 months later, they all had very different ejection fractions. 4 patients, proximal mid-LADs, all presented in a reasonable amount of time, all reperfused, all followed defect-free care. 2 of them with EFs less than 35%. And as the guy who's taking care of these patients, after the cath lab, these people are hard. One of those guys I have to see him every month. He had an LV thrombus. He couldn't tolerate his ARB because his blood pressure was low, and we barely got him on spironolactone, and about 6 months later, we finally got him on an ARB, and now we're moving him to Entresto. This is hard work. This is hard work over the long term. So when Dave talks about, the cost of care over the long term, these are real-life examples. And part of the issue is, Eric and Alex wrote this concept of state-of-the-art Stemi, which we still follow, in 2013. 2013. It's 2025 now. And Gregg showed this, but I'll just remind you, not only because Gregg showed it, but Dan Meanies from University of Michigan, my home, wrote it. The door-to-balloon time is not the only thing. I understand all your hospitals want to hang up a banner saying we have door-to-balloon times that are less than 90 minutes. But the concept here, and the provocative concept here, is we got to be able to do more. And I've spent a lot of time on this dating back to the 1980s, and some of these studies that have been shown that have failed, I've spent time on and published on, and cut up lots of hearts and stained them with all kinds of different stains looking at infarct size. But the problem with all of these approaches is most of them have dealt with either thrombus or reperfusion injury. And the concept of what this seminar is about is to move us away from reperfusion injury to LV salvage. And the guy who's really done a lot of work from the bench to the clinical scenario on this is actually Naveen Kapoor. And if you look at the work out of his lab, which is summarized by his slide here, from over almost a decade of work, showing animal models as well as gene expression, that if you actually unload the ventricle, even during a time of the vessel being closed with no reperfusion, you change genetic expression. You change genetic expression in favor of myocardial viability versus myocardial death. And he tested this in the DTU pilot study, which Gregg alluded to. And this pilot study took patients with MIs, put an Impella CP in all of them. So the first thing they got from the emergency room was an Impella CP, and then in the immediate reperfusion group, they got standard of care, exactly what you would do today. In the delayed reperfusion group, they got 30 minutes of waiting. So like Sandeep says, he scrubbed out, he got and answered some emails, put some tweets out, came back 30 minutes later, opened the vessel. I'm just quoting him. Open the vessel. 30 minutes. The vessel is closed. The Impella is going. You're waiting. Blasphemy, right? Let me show you 2 data slides with respect to this study. One is if you look at the difference between reperfusion, the immediate revascularization group got reperfusion in 174 minutes. The delayed reperfusion group got it in 227 minutes from symptom onset. But look at over on the lower right. The delayed reperfusion group had smaller infarcts, despite a longer, quote-unquote, closed vessel time. This is a paradoxical finding. You don't open the vessel, but the infarct can be smaller. Looking at it a different way, if you look at the sum total of ST segments across the board, the more leads you have ST elevation in, the larger the infarct is going to be, and the delayed reperfusion group in blue had an uncoupling of the size of the infarct compared to expected based on the EKG sum. ST change. Uncoupling, meaning the concept of time to reperfusion with a balloon and a stent is not the only thing we need to worry about. And that has led us to, as Gregg said, the pivotal study, the Stemi DTU, which is done enrolling. We're in follow-up, but we're awaiting these results. And remember, the primary outcome is infarct size is measured by MRI at 3 to 5 days. Secondary outcomes will be a different infarct size, which is percentage of LV mass, complications, which are always important to look at because you're putting in a 14 French sheath, as well as clinical endpoints like development of cardiogenic shock, heart failure, need for VAD or transplant, or ICD/CRT in 12 months. Really, really provocative concept. Because these are disruptive anterior STEMI treatments that challenge us to say, can we actually do better? Are we willing, if DTU is positive, to disrupt care? And Sandeep already laid it out. The two biggest things, the two biggest pushbacks will be very similar for DTU as they are for SSO2, which is why this is a little bit parallel. Are we willing to take the time? Are we willing to change the concept from door to balloon to door to unload in an anterior STEMI? And are we willing to not immediately provide PCI and stenting, but delay that for 30 minutes while we marinate that ventricle, change genetic expression for a smaller infarct size, and obviously you can't put an Impella through the radial. So are you willing to reinvest in femoral access for STEMI? And this is the series of questions that are not only facing us for SSO2, but potentially DTU, but are you willing to do this so that you don't have to manage anticoagulation, ARBs, spironolactone, and Entresto, ICDs, CRTs down the road? What this really is change management. This is change. We debated 25 years ago whether lytics were actually superior or inferior to primary PCI. Debate's kind of over. But there were early adopters that said absolutely, and there were the late majority that said, I'm going to wait. And if you look at why the late majority and the laggards lag, is that we have a false sense of belief that the standard of care is the best. And so I picked a football coach that's not represented by anybody in the panel, but the quote, I think, applies here and leads to the discussion. It's not what you're capable of doing. It's what you're willing to do for the benefit of your patient so that at 3 months, 6 months, and 6 years, is their LV function going to be better? And I think SSO2, as an FDA-approved technology and treatment, as well as the potential for DTU and Impella and LV unloading, offer you these personal questions you have to ask yourself. Are you willing to sacrifice and make these changes in the lab? At that, I'll leave the rest of the time for discussion. Thank you.
Oh, this has been a really amazing session. We learned about how we have to do better with taking care of our STEMI patients. We learned that SSO2 is a really great option and it's cost effective. So I have a question for you, Dr. Jan. So you have done about 100 cases of this now. I want to ask you, how have you streamlined your approach, and how can those of us that don't have SSO2 in our labs streamline our approach and take better care of these patients? Because clearly we have work to do.
Thank you. Well, I think a lot has to do with, education, and I think inspiration. I think, interventional cardiology is one of the fields, I think, which is, it's testament to the Shakespearean saying, what's past is prologue. So, whatever has happened has merely set a stage for the future. So SSO2-like therapies are just in that sense. Initially when you start, there's a lot of shuffling of the feet. If the operator himself is not sure of what he's doing, or if he believes in what he is, to your point earlier, there's going to be shuffling of the feet in the room. So there's going to be some microaggression, there's going to be some obstruction. You'll stand there in the first few cases thinking about what you're doing, but the second, the third, the fourth, when you believe in what you're doing, and then when you represent and you hash your own data, which is very important. So if you are doing certain things and you're not looking at what you're doing, you think you're doing pretty great. But when you look at your own stuff, and then you realize, well, it was not so great. We have done endovascular cases where we have operators who have said they've never had any bleeding from the femoral site. Well, when you review the data, guess what? That's not true. So similarly is the case when you inspire the people, when you stand there for an hour, and I think the staff is also going to stay. And, as I mentioned earlier, Teresa Briggs, who's the educator in the cath lab, who's done a wonderful job. I think you have to have people like this with you to support you. They're not only staff members, but they're also scholars. They represent a generation that teaches as well. And if you have that kind of support, I think it becomes very easy. We have, as you pointed out earlier, you have people who have an entry of all MI, and our staff also ask us, well, are we not doing SSO2? So then the operator feels, well, that was a good question. I should do SSO2.
Thank you for that advice. Sandeep, I'm going to ask you one last question, and then we can conclude the session. You're running the SCORE registry, and that's going to be very important. So in addition to that, what else do you think that we need to do to really get usage going in this space? Because as has been described by all the speakers today, SSO2 is the only therapy that has been shown to be cost-effective and effective in reducing microvascular obstruction in STEMI patients who right now don't do well after an LAD STEMI.
So, it's a great question, Meg. I think, there's a little bit of fear of the unknown. So I think we're overdue for a best practices type paper that just gets to the question that you asked Fuad Jan just a minute ago about how you streamline this. It's not as onerous as you think it is, and there's plenty of other things that you could be doing for that period of time. Also, the label is up to 60 minutes. We've run it out for 60 minutes for the majority of cases that we've done, and Dr. John, I wonder if that's the same in your institution.
60 minutes, yeah.
But there's some people who get squirmy on the table, and we concluded at 40 minutes. It's really not that big of a deal. And I think that there's some skepticism about all the issues that have been raised, that maybe there isn't anything we could improve, which we all know that that's not true, but I think there is this sort of unspoken myth that we're doing great, and there's really, we got the vessel open. I think we've got to just sort of dial that logic back and say that maybe we could do better.
Yeah, so to put the last two comments together, what they're saying is, the metric of door-to-balloon time and in-hospital mortality, we do really well on. And so it's time to really reset where we're looking and look farther in the distance, and what is ultimate LV function of all of our patients that come in with any MI, and how low can we get that, and start focusing on a longer term vision, because our patients actually are having STEMIs younger in life, not older, and they have a lot of potential length in front of them. And so that would be my direct answer to you, is we need to change the metric.
Yeah, because everybody showed it's very clear that we've hit a wall in terms of mortality at this point, right? So next frontier is to try to figure out, not rest on those laurels, figure out where to go. One last question about femoral. What do you think it's going to take to get over that hurdle? Because recently, I think because of radio, I think there are many people who are very afraid of femoral approach. Even when they say femoral, they're just literally afraid of it, and they won't do it. So how do we get the culture changed back again?
I think it's not a big deal, Harry. In our lab, we do 100% ultrasound-guided femoral access. It's a requirement. It's not an option. And with ultrasound-guided, the risk of bleeding is really minuscule. A lot of our operators do radial, and we are a radial-first lab. In that situation, we'll just put a 5 French in the groin. We didn't really talk about the biradial approach. That is an option where if you take a long radial sheath up to the axillary or higher, you can draw back without any issues. So if you have the ability and you went radial first, you can always go biradial and draw with a long sheath. A regular sheath will most likely not work, honestly. I've tried it, and you do get pressure alarms, but if you take a long radial sheath or a sheathless guide, it will work beautifully.
All right. Well, in the interest of time, unfortunately, we need to close. This is a really outstanding session, and I think it is a very interesting time for acute myocardial infarction, too. And I think, well, the challenge of MVO is really one that we need to meet and be working on, and we've got some shots, I think.